Thank you so much, Dr. Andriadis, and thank you very much for inviting me to come and speak with you guys today. I will. Do you guys see the full slide or presenter mode?
We see the full slide.
Okay, perfect. So then I will just go ahead and get started. As Dr. Andriadis mentioned, I did do a sports neurology fellowship. I'm one of the first two, and we happen to both be women, trained in sports neurology, and that was back in 2012 to 2014. The other one is up at Michigan, Dr. Almeida. She's an adult neurologist. And actually, I had done basic science research in brain tumor stem cells, and then totally switched gears in the middle of my residency to what I thought what I ended up pursuing. And so I'm going to give you a talk today about concussion. And we're going to go over really a wide range of things: diagnosis, management, persistent symptoms. And I threw in a few slides in there. Over the last couple of years, we've had a lot of kind of realization that the inequities in health are really prevalent across all different categories and disease states. And this is true in concussion as well. And so I have some slides in there for that. In terms of disclosures, I'm supported by a large team. We had some research. We've had some research funding from a company, Nova Signal, that ended a few years ago, but we're still working on putting out those papers, and then some private individuals who have also supported us. And so we're going to talk about concussion, the definition, how we evaluate, treat, and manage, and develop a treatment plan. We'll talk a little bit about treatment and outcomes based on socioeconomic status and how implicit bias may impact appropriate care of these patients. And so the definition of concussion that we use in the field is based on a consensus statement that was put out by the International Conference on Concussion in Sport. And the most recent iteration was in 2016. They were supposed to meet last year, but of course, with the pandemic, they did not. It's a multidisciplinary group that meets every few years to update kind of on the research and information that we know about concussion, to update the definition. And so they expect to meet this year in the fall. And so their most recent definition is that a traumatic brain injury, concussion is a traumatic brain injury induced by biomechanical forces. And it can be a force that's applied to the head or the body. So we don't always think about the body, but if it's to the body, it can be transmitted to the brain. The signs and symptoms may evolve over minutes to hours. And it's functional disturbance, not a structural injury. So we don't see any abnormalities on standard structural neuroimaging. That's important. We have a lot of research coming out in kind of multimodal MRIs right now, in the DTI space. We even have some abnormalities we've seen on MRS, but those are not things that we use clinically yet. It's a graded set of clinical symptoms that may or may not involve loss of consciousness and cannot be explained by any other reason. And so this is what the time course of acute pathophysiology looks like in an animal model. And so you can see over the first few minutes to hours, there are a lot of changes in the brain at a cellular level. And you can see, importantly, also down here towards the end, we get a decrease in cerebral blood flow. We get changes in glutamate, lactate, glucose, all of the things that the brain sees really changes over this first few hours, minutes, hours to days. And this is the result, is that we see all of these symptoms and cellular changes here in the brain. So what are these signs and symptoms? And as many of you know, if you've treated patients with concussion, they're really nonspecific. And so we can see any of these number of symptoms with migraine, for example. So a lot of these physical symptoms that we see after a concussion are very consistent with having migraine. Teenagers fall into this bucket frequently. They're irritable. They may feel more emotional or nervous. They may have sleep disturbances. And then cognitive is the other bucket that we kind of throw all our symptoms into. And you can see that the number of symptoms that patients present with are really here down in the kind of single digit range. There are a few that'll present with more, but they tend to kind of divvy themselves out into one of these few buckets. And that's one of the things that we're going to be studying at UCLA in a multi-site study with pediatric patients, looking at kind of endophenotypes. And so the categories that patients may fall into after a concussion, because we feel like there are different types of concussions depending on how you present. You can see that the most common naturally symptom that we see after a concussion is a headache, dizziness not far behind, and loss of consciousness is way down at the bottom. Really, we only see loss of consciousness in about 2%. And this is important because, you know, I think in the olden days, back when I had concussions, I'm a horseback rider and I have been for 40 years. And so in 8th grade, I remember I had actually one that was accompanied by loss of consciousness. And that's how we used to think about concussion. But now we know that this is very rarely present. It's important to kind of contextualize what we see in the concussion field, that there are disparities that exist, and these are geographic, socioeconomic. There are gender differences as well, and it's just important to remember that this is the case, so that we can approach each of our patients and really take care of them individually, and from the framework of knowing that they may have knowledge of concussion that is different than other patients that we see. And it really, this is important here, because this can really play into how our patients understand and comply with the management recommendations that we give them. Underreporting is also affected by social norms. And so that's another thing to consider, is that we may not be seeing all the patients that have concussion, because they may not be reporting depending on what their background is. And we want to approach this because it's important. We may be able to figure out ways to decrease risk in the field, depending on the disparities. This is a way that we can improve care for all populations. And globally, there may be strategies that we can decrease healthcare costs, because patients that have a deficit in their knowledge of concussion or how they use the healthcare system really leads to increased cost. Oh, whoops, sorry. And so in this first study, this is a youth style study survey that was administered by the CDC back in 2014. And this is given out to parents who are members of this knowledge panel, and they had kids between the ages of 12 and 17, and there were 1,000 respondents, and about a little more than 50% of them played sports, and they were included in this study. And the objective was to identify the predictors of concussion education. And so we can see, and the reason this is important is because if you have adequate concussion education, you're more likely to report, and actually this is about 3 times more likely to report a concussion than someone who has not received education. So these are the questions that they asked. And this is the demographics. So you can see they ranged, it's really kind of split pretty evenly, although there were fewer in this older age group. This was the breakdown from race and ethnicity. It's about a 50-50 split for gender. Most of the parents did have some collegiate education, and the household income breakdown is here. And when you look at the factors of those who receive concussion education, you can see if they had a past concussion, they were more likely to receive concussion education. That makes sense, because if they've had a concussion and went to the healthcare provider, they should have been educated with some after visit recommendations. There was a difference in male and female. So females were less likely to receive concussion education. And then the other big one down here is you can see that there was difference here in household income. So depending on your household income, you were more or less likely to receive concussion education. The next thing that these authors did was, interestingly, they split out concussion education, and whether you lived in a metro or non-metro area. And here you can see those in the lower socioeconomic group who lived in a non-metro area were less likely to have received concussion education compared to those who were in the higher socioeconomic group. But the other interesting piece, and this is not statistically significant, but you can see here that if you were in a metro area and a lower socioeconomic group, you were more likely to receive concussion education. And I think of these guys as the probably city dwellers here, and the non-metro is probably, in this socioeconomic group, is probably rural, versus here where you're looking at city or metro versus suburban, which I think suburban and rural are very different. I'm not going to talk about rural injury today, but there are a lot of differences that we see in the rural population. This is another survey study that was done. Sorry, not survey study. This was another study that was done looking at coaches' education. They wanted to look at whether race, ethnicity, and location in the United States predicted whether you received education as a coach. And this is a USA Football. This is USA Football data. So USA Football has a heads up football education program that was designed to address concerns about safety in youth football. And so coaches can voluntarily take the certification, which takes about 2 to 3 hours, and includes training in concussion recognition and response, proper equipment fitting, and strategies to better coach youth football participants. And they looked at this data, the authors of this study looked at this data to see where coaches were being educated. And you can see that there is a difference here in terms of where you were located. So coaches that were in the Northeast region, East North Central regions were more likely to have heads up football certification. And if you lived in the South Atlantic, East South Central, and West South Central regions, you were less likely. And these are areas in which football is, a really prevalent sport. So it's important to know that in these areas, they're not receiving that education, at least at the coaches level, as much. So let's talk about who gets concussions. And this is actually older data back from 2012. So almost actually a decade ago, these epidemiological studies were done. This is important to know that about 4 million there are 4 million concussions that occur annually. And this is probably an underestimate, although we're probably getting a better idea now as concussion recognition has increased over the last decade. But many concussions don't actually go to see a healthcare provider. So that's why we think this is an underestimate. There are about 8 million high school participants annually in sport. And the breakdown is about 3 million girls, 4 million boys that participated in this kind of decade or this academic year here. And 2 million of them participate in contact and collision sports. And that's why it's important that we educate ourselves and participants, parents, coaches about concussion. The injury rate for concussion is higher in competition for some sports than in practice. And you can see what the sport breakdown here is. And so this is at concussion as a percent of total injuries. And so we're looking at, in football, concussions make up a little more than 15% of the injuries. In ice hockey, this is a little bit more. Girls lacrosse. Importantly, we often don't think about cheerleading as a sport, and schools also don't approach cheerleading as a sport. And so these are participants who are practicing on asphalt. They really don't have good practice conditions. They don't maybe have as much coach oversight. And so we can't forget about these folks out here that are participating in the sport. So I just wanted to show you about in this study, looking at competition versus practice. And so you can see here, in many of these sports, we do see that the rate of concussion is higher in the competition setting than practice. You can see here swimming. I'm actually on USA Swimming Concussion Task Force, and you wouldn't expect many concussions in swimming, but they occur at an equal rate almost. I think this is because, in competition, it's just a single person per lane versus in practice, you have multiple people in lanes and you could be bumping into each other, causing the concussions. And then these are the rates in boys versus girl sports. And you can see here that in girl sports, there is a higher rate than there is in boys sports. And we'll talk about that in a little bit. The overall total here, I've just highlighted. So in terms of girls versus boys in concussion, we see that in sports that are played the same. So looking at soccer, they have the same rules between male and female athletes, basketball the same. Baseball and softball work, we look at together, they're obviously a little bit different in terms of rules, but they're very similar. And you can see that the rate, both in high school and collegiate population, is higher in girls than it is in the boys sports that's played comparably. And we don't really know why that is. There's a lot of investigation looking at that. The older research in concussion was really focused on boys or men's sports. A lot of the information comes out around football because it's a collision sport and there's a lot more data. But now we're starting to look at girls sports as well, and we're seeing this difference. Now we don't know if there's a cultural difference. Girls may report more, and there is certainly some data looking at that or supporting that. There is some physiologic difference. So girls have less neck strength and shoulder girdle kind of mass here. And so there are some researchers looking at whether that plays into the rate of concussion. So that might be, there's probably another biological reason, and investigators are looking at hormonal contribution. This has been really difficult to kind of look at because when they're looking at girls or women who are having concussions, they could be at different points of their cycle, and we've been trying to pin down in the field, are there parts of the cycle that you're more likely to sustain a concussion? But the data has been kind of mixed. Other risk factors for concussion, and some of these are also risk factors for prolonged recovery after concussion, are previous concussion history, age. So we see that, we see a lot more concussion in this adolescent age group. We talked about sex already, level of play can play in. And then these are important here: history of headache, history of ADHD and learning disabilities, and then presentation with somatization symptoms also predispose you for having both concussion and prolonged recovery after a concussion. One of the things we were just talking about the differences between gender, and I think this was an interesting study where they looked at, and I'm just pointing out here, boys soccer and girls soccer, and the mechanism by which boys and girls sustain their concussion. So they had divided it up into contact with another person, contact with the surface, or contact with equipment. And we can see that even at this level, there is a difference between how boys get their concussion versus how girls get their concussion. So in boys, it was more likely concussion was sustained by contact with another person, whereas in girls, it was contact with equipment. So this could be goalpost or soccer ball. This was a retrospective study looking at athletes in Hawaii, and it looked at about 10,000 athletes, and they used impact data, and we'll talk about impact a little bit later, but it's a computerized cognitive test. Hawaii actually has a really good concussion surveillance system. Obviously, it's a small school district, or and they have a pretty good handle on and collecting this information through the athletic training system that they have there. 12% of concussions were seen. It's a pretty even split, about 5,900 males, 4,400 females in the 67 public and private middle and high schools. And again, this was through the Hawaii Concussion Awareness and Management Program. And what we see here is that the highest risks were in wrestling and cheerleading, again, thinking about cheerleading as a sport. And they also saw positional differences. So looking at just the sport of football, where there are very different positions for players, they saw the risk was highest if you were a running back. And then looking at age group risk, in this kind of young adult age, around 18 at that threshold between kid and adult, that's where they saw the most concussion risk. This was a retrospective study looking at patients who sought treatment for concussion to a sports medicine clinic. And the reason I threw this slide up here was just, I wanted to point out that we think about concussions here in the organized sports setting, but we also have to think about in the school setting that it does occur. And we may see patients in our practice who sustain concussions in other settings, so recreational activities. And so those are not organized sports. So for example, it's winter right now, we see a lot of skiing and snowboarding injuries, or we may see motor vehicle collisions. So we really want to make sure that we don't forget about these folks in our concussion clinics. And that gender difference does exist even in this population. So even looking when you separate out school setting, motor vehicle collisions, you can see that there's a difference here between male and female rates of concussion. I mentioned already that the risk of repeat injury does exist for a history of prior concussion. Certain sports predispose you for having risk of repeat injury. And I think those of us who take care of kids, one of the questions that we get asked, or we may even ask ourselves, is how do we assess and balance the risk versus the value of sports participation? And so we really want to think about, is some measure of injury an acceptable compromise for the physical benefits that are associated with physical activity? And is there a way that we can develop abilities to appraise and deal with the risks, or that we can have our children, grow up appraising risk? Risk is assessed relatively. So it's usually, we say it's high or low compared to another activity. So risk in a collision sport is higher than risk in a contact sport, is higher than risk in a non-contact sport. And the acceptability of risks that we may undertake, or a kid or his or her parent may undertake, is a relative value also. And there's really no number or threshold value that can tell us what is acceptable risk or not. We who have been trained in pediatrics know that sports participation and physical activity yields a range of physical and psychological health benefits, but injuries are predictable, and specifically concussions can be predicted if you're participating in a collision sport. And does that mean they're preventable? So there are people in the field that work with childhood injury that feel that all childhood injuries, irrespective of origin, are unacceptable. And our perception of risk can be clouded by many different sources: scientific data, expert comments, media reports, peer group views, and personal observations. I get asked in clinic a lot, or when I give talks out in the community, how do we decide, should our kid participate in sport? Football gets asked a lot, but it's important to remember that in girls, soccer is the sport that yields the most concussions. And I say that, physical risk, so sports participation is important, and physical risk may actually help children to develop risk assessment skills. Maybe it helps them to develop self-affirmation, to become more confident. And so there are some health benefits to participating in contact and collision sport. And so we talked about this already, but then even looking forward to when our children become adults, it's important that they've participated in physical activity as a child, because that predicts whether they will participate in physical activity as an adult, which does play a role in developing some of these adult types of diseases that we see. But even, obesity is a childhood epidemic as well. So what are some of the ways that we can reduce risk? Well, there's protective equipment. And so it's important that in the sports in which helmets are recommended or required, that we have our children wear helmets. And so, in the recreational sport field, when I see kids in clinic, I always ask them if they're wearing helmets in ski and snowboard sports, if they're wearing their bike helmets. We want to make sure the helmet fits properly because kids and adults are not going to wear their helmets if they don't fit very well. Helmets can be productive in this situation. Of course, helmets don't prevent concussion. They usually prevent more severe injuries, especially in our high velocity sports. In terms of headgear, this is another question I get asked. The data is kind of mixed about the use of headgear in soccer. And one of the things that I get concerned about is that, if you're wearing more protective equipment in this setting, you may feel like you're less at risk for a concussion and put yourself in a more risky situation. So you may go up for more headers thinking that, oh, I have a headgear on, it will protect me from concussion. The other situation is that, unfortunately, even in youth sports, and we've seen recently with the unfortunate suicide of the Stanford soccer player, there's a lot of pressure in youth sports. And it can be actually very vicious out on the field. And if you're wearing a soccer headgear, it might mark you as someone who's had a concussion before or who worries about having a concussion. And then you may be subject to taking opponents' elbows to the head or strikes to the head. And so that's another thing that concerns me about headgears in sports, where it's not necessarily, the data is very mixed. There are helmet and headgear ratings, and these are out of Virginia Tech University. They've been looking at different helmets to rate them. And so, you can send your patients here to look and see if this is a helmet that they want to purchase. I'm really excited because they've just started looking at equestrian helmets, which in talking to both of these guys, I've learned that the equestrian helmets are actually very horrible. So that's unfortunate. Other things that we can do to reduce risk in participating in sports are policy and rule changes. And we've seen that they've stopped allowing body checking in youth hockey, and this has led to good reduction in concussion risk. In the NHL, there's greater enforcement of penalties. That's helped. It hasn't helped in the youth population, but that might be because we already changed some of the rules. Stricter enforcement of red cards in soccer. In many states, they have reduced the number of contact practices for our high school football athletes. And so for here in California, our high school football practices are limited, the contact practices are limited to 2 per week, and they can only be 90 minutes in length. I mentioned the Heads Up First Education program earlier when I was referring to that study. They've changed the sizes of ice rinks for our little youth hockey players. And then, of course, I just mentioned there's some legislation here in California limiting the number of contact practices, but there's legislation in all the states about concussion education and how to manage concussion if one is suspected to have occurred on the field. So I thought I would illustrate some of the management, evaluation and management through a case. I picked a 16-year-old because I felt like that would be we have a mix of adult and pediatric neurology providers here. And I wanted to make sure this was kind of an age that might be seen by an adult neurologist or a pediatric neurologist. This is a 16-year-old girl that has a history of migraines. So even before her concussion, she does have a premorbid history. She presents to the ED with vomiting after sustaining a concussion during a soccer game earlier that day. She took an elbow to the back of the head and saw stars, but she didn't have loss of consciousness. So she kept playing and she developed a worse headache and left the game eventually. She's had migraines for 2 years. Mom also has migraines and dad has ADHD. And I just want to point out some of the things that we talked about that predispose you for having risk of concussion and risk of prolonged recovery. Migraines, she has migraines here. She continued playing despite having had the concussion. And then she has family history of both migraines and ADHD. All of those things individually. She's also an adolescent girl. And so all of those things predispose her for having concussion and having prolonged recovery. If we were at the sideline, so, some of you who are parents out there may be there at the sideline of your kids' soccer practice or football practice and called upon to do the emergency management if a concussion occurs, of course, we always start with GCS and then look for some of these signs of deterioration. Spinal injury and neck injury is very important to look for. And so we look at these observable signs here, but and these are the red flags. And we all know these as neurologists. These are red flags of a serious injury, and these individuals should be taken by EMS to the hospital. The SCAT-5, which is the sports concussion assessment tool that gets used on the field, starts with Maddox questions, and these are orientation questions. So what venue are we at today? Which half is it? Who scored last in this match? What team did you play last week or game? And did your team win the last game? And the thing that's a little bit tricky is some of these don't apply to all sports. This was originally developed with football and soccer in mind. And then the other thing is you have to know the answers to these questions yourselves if you're going to ask these questions. Cervical spine assessment is very important. That's one of the first things that we do. In somebody who's not lucid or fully conscious, we should just assume that they have a cervical spine injury and treat them that way. So the sports concussion assessment tool, and we'll go through it, has a graded symptom checklist, an assessment of concussion that's like a mini cognitive test. There's a balance test here. And the utility of this is really in the acute time period, although we use the symptom checklist to track recovery over time. It should take about 10 minutes to complete. So for us neurologists, that's a pretty quick exam. And the athlete should be in the resting state. So you don't want to pull someone just off the field and have them try and complete this. In this new version, so it's actually several years old now, and they'll update it, I assume, this year. There's some pre-morbid questions. This is new here, which is good because it also, it references that there are risk factors for concussion here. And then here is the cognitive assessment, or the standardized assessment of concussion. And in the acute period, the sensitivity and specificity are pretty good. There's an orientation, immediate memory. So you give them a list of 5 to 10 words, and their lists are provided on the SCAT-5. And you have them repeat them 3 times. You don't tell them that they have to remember the words, but you will ask them later what the words were. You have them do digits backwards, months in reverse. And then right here, we throw in a neuro exam. The neuro exam for the SCAT-5 is here, and I'll go over it in a minute. But the neuro exam that we do is we focus on cranial nerves, and this is what we do in our clinic because these are most likely to be affected after a concussion. I do a brief motor tone and strength exam. I just check light touch for sensory and have them do coordination, finger to nose. I don't typically check reflexes if I'm in the acute setting. And then the other piece is Tandem Gate. So you have them walk 3 meters on a line, and you want them to walk heel to toe. This is the neuro exam that's in the SCAT. So you have them read the instructions aloud. You have them do passive cervical spine movement. You look for double vision, finger to nose, and Tandem Gate I talked about already. This is the balance test that we use. It's called the balance error scoring system. What you would use on the sideline is you would do the modified best, which is just these top 3 stances. So feet together, hands on hips, eyes closed. Then you have them stand on their non-dominant foot, and then you have them do a tandem stance. If you're in the office, and we use this foam pad here to do the full best, and that increases the sensitivity of the test. And these are the errors. You have them hold these positions for 20 seconds, and you count the number of errors that they have. And then you make a decision. So you add up all your numbers, and you decide, does this look abnormal for them? If you have a baseline test, sometimes that makes it easier because you can compare to their baseline. But scoring should not be used as a standalone method to diagnose concussion. And we never use the SCAT-5 in isolation, but we take into account their history and the rest of our exam, and even some cognitive testing. We have a neuropsychologist that works with us on our team, and the neuropsychologist may do some cognitive testing for us. On the back of the SCAP-5, there is concussion injury advice that you can provide to your patient. Again, this is in the acute setting, so you're telling them they've received an injury to the head, and if they notice any kind of alarming signs, they want to go to the ED, but in that immediate period, they should follow these directions here. And I just wanted to show you what the SCAP-5 symptom checklist looks like. And so we have a lot of symptom checklists at our disposal. The SCAP-5 had for the children, and this is designed to be used from age 5 to 12. There is a child report and a parental corroboration of the child report. And they rate them. It's a Likert scale 0 to 3, parent, same thing. We don't, in our clinic, use the SCAP-5, the child SCAP-5, because some of these questions in this age group seem like they probably don't understand the wording of some of these questions. And so instead we use the post-concussion symptom inventory. There's a 5 to 7-year-old version. You can see these are a lot easier for them to understand these questions. There's 8 to 12, and you're rating before and currently after the injury. And there's 13 to 18, and then a parental report as well. We expect symptoms to get better over the first few weeks, but we have seen, and I mentioned already, some of the additional imaging modalities we've been using in the research setting. And we can see that there are differences, or there are signs of kind of prolonged physiologic recovery on MRS and in cerebral blood flow. And then also in DTI imaging, we've seen abnormalities up to a month. Okay, so we've examined our girl. She has a symptom score of 25. And I can tell you that having done baselines in the high school setting, girls, boys and girls in that age group can typically have symptom scores in the teens, even just at baseline. So 25, not so bad, but she does have some symptoms, and they're predominantly in the headache or the physical category. The rest of her exam is not very exciting. And so are there other diagnostic evaluations that we should use? And should we obtain imaging? And so in the field of TBI, we use this study. We refer to this study when we're in algorithm, when we're deciding whether a patient should get a CT scan. You know, many, we're both, and I say both, meaning all of you at Downstate and I at UCLA, we're in an academic setting. Getting an MRI is fairly easy, especially in a teen who can lay still. And in little kids, we can't get an MRI so easily. So we may, just rely on an MRI. But in most hospitals, a CT would be the first thing that we would think of getting. And so this study was looking at kind of evaluating whether kids should get a CT or not, and especially in this population where we worry about the exposure to radiation. That's why this algorithm was developed. And so if you look at this age group, and this is the above 2-year-old, there's a different algorithm for 2-year-olds and under. You want to look at these things first. So GCS, altered mental status, or basilar skull fracture. And so if you say yes to any of these things, what they saw in their study was that you had a not insignificant risk of having what they call a clinically important TBI. And so that means that you need neurosurgical intervention or admission to the hospital for closer monitoring. And so for these folks, if you say yes here, you do recommend a CT. If you say no here, then you go to this next level and you ask these questions: loss of consciousness, vomiting, severe mechanism of injury, or severe headache. If you ask yes, or if you answer yes here, you have about a 1% risk of being in that group of needing neurosurgical intervention or getting monitoring for closer follow-up in the hospital. And so you could go either way. You could either get a CT or observe. Physician experience may play into this. Other findings may play into this if they're starting to worsen. Parental preference, and I'm going to show you a study that's interesting in a few slides about this. Otherwise, if you say no to these, then don't get a CT. You have a very low risk of having a kind of serious TBI. And so I pulled this off the California website, but there are algorithms here that make the picture really easy to follow here. And I just highlighted here, our patient has vomiting. So she would fall into this bucket here. We would maybe observe her versus maybe getting a CT. The other thing on this picture that I think is just good to highlight is that the severe mechanism of injury for this age group above the age of 2 is this here: fall greater than 5 feet. There was an MVA in which someone was ejected, there was a rollover or a fatality. In a bike versus pedestrian or bike versus vehicle injury, or if they were struck by a high impact object. And so I just wanted to point out this study. So going back to our health inequities, what they saw, and this is actually the same group, that PECARN group, looking at who was likely to undergo diagnostic imaging. And so they divided patients up into race and ethnicity, sociodemographics, and clinical characteristics. And what they looked at was whether they were likely to have risk for clinically important TBI and the likelihood that they would get a CT. And what they saw was patients who fell into and they had to combine because of their N. Even though this is a really large study, you can see that there are thousands of patients in each group. But if you were white, you were more likely to get a CT. And I just want to highlight here, even if you fell in this lowest risk of clinically important TBI, versus if you were non-white, then you were less likely to get a CT if you fell in this group. And the reason, and they looked at the reasons for why these patients were more likely to get a CT, and this is a pretty high number. And the reason was parental anxiety or request. I find that pretty interesting. This is not isolated to just neuroimaging. Here's another study here looking at other conditions. So these are a whole bunch of other, organ systems, and whether they were more likely to get imaging. And all of these conditions favored imaging in non-Hispanic white children versus non-white children in this study. Okay, so back to our patient. She was discharged from the ED with precautions, return precautions, and she's advised to see her primary care provider in 2 days for follow-up. She would like to be cleared to return to soccer since she has a game tomorrow. And so should we get computerized cognitive testing to determine if she's recovered? And so I just wanted to kind of comment. Many of you may know that there are a number of computerized cognitive tests out there. Impact is probably the one that is most utilized, and I can show you the pie chart for that. But we do not use computerized cognitive testing for diagnosing in an isolated way. We can use it as an adjunct to clinical assessment. And in the beginning, before we had our neuropsychologist, we did use this a lot more, but we have a neuropsychologist now. And so we use brief paper and pencil testing at this point now. And so this is the pie chart, and you can see Impact takes up the largest kind of market share. They were just the best marketed, but there are other types of cognitive testing out there. But I do want to point out, and this is a baseline test study. So this was looking at almost 1,000 high school age participants from 10 high schools in the Northeastern Ohio area. And they ended up including about 500 high school athletes between the ages of 13 and 18. And what they saw was that race was significantly associated with all performance scores on baseline computerized neurocognitive testing. And that was independent of sex and socioeconomic status. And what they also saw was that there was a difference in baseline symptom reporting as well. And so I just want to highlight this, because if you are comparing to normative data, it's important to take into account that normative data lumps everybody together, and we don't have race-specific normative values. So if you don't have baseline testing results for your patient and you're using the normative data, just to consider this. In fact, in the NFL, there was just a big decision that was made that they can't use the normative data when looking at the patients or the NFL players that have been retired and are looking for some compensation from the league at this point. And so I also wanted to highlight in this next section just the use of the ED and how patients are evaluated in the ED. And so this was a retrospective cross-sectional analysis of ED visits from 2008 to 2017. And this was using the National Electronic Injury Surveillance System data. And that reports population weighted estimates of injuries and consumer product related injuries. And so the objective of this study was to assess if race and ethnicity was more affects the likelihood that a sport related visit to the ED was for a head injury, and whether they would be diagnosed as concussion or whether they would be diagnosed with some other type of diagnosis. So contusion, internal injury, or even other injury as another possible category that they could be diagnosed with. And what they saw was that Black children compared to non-Hispanic white children were less likely to have their ED visit be for head injury or diagnosed as concussion, and instead they were diagnosed with one of those other diagnoses, so contusion, internal injury, or other injury. And the reason that this is important is because if we're diagnosing a patient with concussion, there is a protocol and there are already set recommendations for that patient. In addition, they'll leave their ED visit and say, I had a concussion, and they're the stakeholders on the outside, so like the athletic trainer or their coach or even their parent knows what to do with that information. They have to follow a guided return to play protocol, return to school protocol. But if you diagnose them with internal injury or other injury, they don't have that same understanding of what they should do in the follow-up period. And so we're really not giving them good guidance if we're diagnosing them with some other injury. And this is true in certain sports. So in basketball, cheerleading, field hockey, soccer, this is particularly apparent. The other thing the other inequity that was seen, and this is in the same database, but in a different study, was they looked at the number of, or the children that had left the ED without being seen that had a sports-related concussion. And these children were more likely to be non-white, and they were more likely to have had their concussion occur at a place of recreation rather than at school. So that's another thing to consider, is that we may not be getting to these kids as well. Okay, so now we've diagnosed with a concussion. And so what are the management recommendations? And this is something that's changed over the last several years, is how should we prescribe rest? And so when I had a concussion back in 8th grade, I was told, you rest for a week, no activity for a week, and then you can just go back to your sport. And for me, that was riding. And so the doctor that I saw said, that's how I would, proceed in the immediate period after a concussion. But what we're seeing is that prolonged rest actually may prolong symptoms. And this is based on a few studies that have come out over the last decade. And these are just two of them. So in this first study, what they saw was that, and they were looking at, and this is in a single study, unrestricted activity versus other types of lower activities. So this unrestricted activity is like just they're doing anything. But in this first, second, and third quartile, they're just doing lower levels of activity. So they might be reading a little bit less, and this was cognitive activity specifically, they might be doing a little less homework. And what they saw was that while unrestricted activity predicted longer recovery, all of these other kind of less lower levels of activity all recovered about the same. And then there was this study the next year that was published, and they looked specifically at strict rest here versus usual care, which was that patients in this bucket were told just rest a couple of days and you can slowly go back to activity. And what they saw was that the patients that were in the strict rest category, who were told to rest for 5 days, actually did worse, had a longer recovery than those that were resting just for a couple days. And so, this leads us to looking at what predicts persistent post-concussive symptoms. And so those patients that are told to rest for long periods of time may have prolonged symptoms, but what are the other things that predict? And this was a study that was done about, I guess, 6 years ago, and they looked at the risk factors for prolonged recovery. And they found that in these categories, so age in this adolescent age group, 13 to 18, female, having had a prior concussion, having a migraine history, these were types of things that that put you at risk for having persistent post-concussive symptoms. Now, what do we do with this information? So certainly if we're seeing the patients in the acute period, we're not telling them, oh, you're going to have prolonged recovery, right? So if you see them in the ED or if you see them in the first couple of days, you're not going to say, oh, your symptoms are going to take a long time to recover, but rather you might have closer follow-up with them, or you might send them to a specialist sooner if you start to see that their symptoms plateau. So what is the harm in prescribing this kind of prolonged rest that we've talked about? So let's say here's the patient having had an initial injury, and we've prescribed rest and activity restriction, especially in our teenage age group, where they may be participating in sports, they may be part of a team, that's a big part of their identity. If we restrict their access to their sport, then we see a lot of mood changes, they get stressed and anxious. They also become deconditioned, sorry. And because of these symptoms, we would say, okay, rest some more. And so they would have worse symptoms, and we come back in this cycle, and that really leads to a functional disruption for our patients. In terms of recovery, I just, wanted to point out too that we see that recovery does differ by race and ethnicity and insurance type. And so in this retrospective observational cohort study, and this is from clinical data from medical records at a university-based concussion program from 2012 to 2015, they found that, the typical risk factors for prolonged recovery that we've talked about exist. So prior history of concussion, a history of ADHD. But what they saw, interestingly, was that here, white females did take longer to recover than the other groups. And so the other groups here, specifically the Black and Hispanic males, Black and Hispanic females recovered quicker than the white females. And these athletes, the Black and Hispanic athletes, were more likely to be in the lower socioeconomic status quartile and possess public forms of health insurance. So not surprisingly, when they looked and they looked at their data for health insurance, what they saw was that public forms of health insurance and student athletic insurance also predicted shorter concussion recovery. Now, it's hard to know because it's just in the beginning of looking at these inequities in our field. It's hard to know why this is. Do these patients get better? Do these patients truly get better? Are they just reporting that they get better sooner? One of the things that's complicated for us in California is that our California Interscholastic Federation requires that patients see us twice after a concussion. So they have to be diagnosed with a concussion and then cleared for return to activity. And that can be very burdensome for patients. But is it more burdensome for patients who are in this race and ethnicity or have public insurance? Are we seeing that in this population, both parents are working and cannot take the child to the doctor? And so they will just say that they've recovered so that they don't have to make multiple visits spread apart in time. So I think these are things that have to be looked at a little bit more. It's important for all of us as neurologists to know what the concussion legislation is in our state. All of the states have concussion legislation, and it is state mandated, so it's different for each state. But I pulled yours because I was interested to see how different it was from California's. And it's very similar. So it says that all school districts do have to have concussion management and awareness and some education and a protocol that they follow. They have to provide education to participants in the sports as well as school officials and coaches, provide information to the parents. And then in the case of a suspected concussion, the athlete has to be removed from athletic activities. And the law is written that it says that they should be evaluated by a licensed physician. This is true in California as well. Ours also says that they have to be evaluated by a physician specifically. And this is different than some other states have a licensed healthcare provider. And so in other states, this can be a neuropsychologist, a psychologist, a chiropractor, a physical therapist. So it's not necessarily a physician in some states. And then the last piece for your legislation in New York is that there has to be a management team in place. And so this can include school officials, coaches, athletic trainers, etc. There was a multidisciplinary group that put out these guidelines back in 2018 for guidelines for concussion management. And this has some specifics about if the injury occurs at school in a school athletic activity, who can diagnose, who clears the patient, and who has final clearance. So there's some recommendations about this. And then very similar to the SCAP-5, there is a graduated return to school strategy that was probably adapted from there. And so you can see symptom limited activities. So we no longer recommend rest specifically or strict rest, but say that they can do daily activities at home and they can slowly progress up to returning to school full time. The development of graduated return to school activities or return to school strategies has just been kind of adopted over the last several years. And this is important. We're finally focusing on activities that our kids need to get back to. And then following that, oh, whoops, sorry, I put return to school activities twice. I meant to put the return to play activities next. But it's similar. It would be activities slowly over time, increasing from non-contact aerobic activity up to contact sport clearance. And you can see here, actually, here's another version of it. And this is a template that is provided by your state that you can adapt for your patient care. So you can see here are accommodations that you might recommend for your patients in the school setting. And then here are the athletic accommodations, but then here's the athletic return to play. So you have them begin with aerobic activity that only slightly increases heart rate and slowly increasing heart rate and body and head movement to kind of heavy aerobic activity all the way up to full contact practice. And this template also has a concussion information sheet for students and parents that they can look at. In terms of resources, this was pulled from the New York State Department of Health. And so, and this is on the injury prevention. There are a lot of different resources that you can click on yourself, or you can point your patients and their families to. A lot of these are actually pulled from the CDC website, and this is the Heads Up CDC website. And so this has a lot of good concussion information. You might want to look at the provider section, but there's a parent section. There are a lot of different things that you can look at. You can look at the concussion laws. The AAN also has sports concussion resources. In the past, the AAN has had a sports concussion conference in the summer. We are not having it this year, and it may get lumped onto the fall conference this year. And then here's a pediatric mild TBI guideline that you can use as a checklist if you're treating children between the ages, younger than 18. And it kind of gives you some algorithm to follow. So just in summary, concussion is a traumatic brain injury that results in self-limited neurologic signs and symptoms. There are risk factors for concussion and prolonged recovery after concussion, which are listed. You want to use validated clinical decision rules to identify those in whom neuroimaging is not indicated. You want to recommend a brief period of cognitive and physical rest and then introduce symptom limited physical and cognitive activity. Providing education and reassurance for the family and the patients is really important. And if they continue to have symptoms after a prolonged period, then you would send them for formal evaluation, or you might see them in your clinic for formal evaluation if they've been referred to you from their primary care provider. And then just as a last really important point, there are healthcare inequities and disparities in education. And we should provide targeted outreach and education to these populations, and then also provide appropriate individualized care. So that concludes my talk, and I really want to thank you for your attention. We have our own website at UCLA for our concussion and sports neurology program. My colleague, Chris Giza, is very active on Twitter. Not only sports stuff, but all sorts of neuro and other interesting things are on here. So if you want to follow him, I'm not as active, but if you want to follow me, I'm here. We have a Brain Sport Twitter. And of course, if you have any questions, please feel free to either ask me now or reach out to me by email and ask me.
Dr. Choe, thank you so much for such a wonderful talk. If anyone has questions, they can either unmute or put it in the chat. One question that I was actually curious about, I know that we tend to see a lot more, school-aged athletes getting concussions. However, I feel like there's not as much research and guidance regarding concussion in toddlers. So if you're giving them any advice regarding return to play and return to school, because a lot of them, of course, are not necessarily in daycare. They might be home with the parents. They might not be doing sports, but they're very, very active once they start walking. Is there anything about those parents?
So I typically tell them to just monitor, for the first couple of days, maybe give them less activity, don't let them climb on playground equipment, that sort of thing. And they can slowly liberalize. The other question I get a lot, and I'm just thinking about this because I'm thinking, oh, if my toddler were awake right now, I'd have plopped him in front of a screen so he would leave me alone while I give you guys your talk. But screen time is another question that I get asked a lot about. And actually, some screen time is probably okay, especially, when we worry about our teenagers that are, always attached to their screen. If we say you cannot use your screens for a week, then they will become very depressed because they will not be able to socialize with their friends. So we usually say, a few minutes here or there is okay. So in the toddler population, I would probably say the same thing. Don't plop them in front of a screen for a long time, but you can let them use a little bit of screen time. That would be their, maybe cognitive or focusing activity.
Thank you.
Any role of magnesium supplements? We use magnesium kind of more in the chronic stages. I actually haven't seen this paper, but I will check it out. I don't know what the benefit would be in the acute concussion phase. There really haven't been, and again, I haven't looked at this paper, so I will definitely check it out. But most concussions just heal on their own. And we think, 80% is just, they're going to get better on their own. And it's hard to do these kind of intervention studies to look if we can speed up the recovery, because we know so many are going to heal on their own. And there is kind of a wide range of recovery time. So kids can recover anywhere within the first week to take up to 3 to 4 weeks to recover. But thank you for pointing that study out. I will look at it. We use magnesium in the chronic phases sometimes as our intervention for chronic post-traumatic headache. If you're out at 3 or 4 weeks and the parents or the kid doesn't want to take a prescription preventive medication, then we might say, okay, let's do some magnesium. Maybe we might add in some B2. I often say MigraLeaf because MigraLeaf has it all put together, and you don't have to have patients going out and buying multiple things. Other questions?
Anyone has some questions for that?
I'm pulling this study right now. Decreases symptoms acutely. at
May
48
I ask you a
hours.
quick question?
Uh-huh.
Thank you for the wonderful talk. It might be a obvious question, but you mentioned that in your exam you do a cranial nerve exam, and then the rest of it is like more like brief. But
Mhm.
the reason that you care more about cranial nerve exam is that you worried about brainstem. You just want to make sure there's no brainstem injury.
Mhm. I've seen both fourth and sixth nerve injuries in con in concussion. We would probably call those more complicated mild as opposed to just mild TBI because there is a neurologic deficit. Um, so that's why we focus on there.
Thank you.
I just pulled the abstract up for the study, and it does look like it is promising. It's hard with these treatment studies, right? Just like the CHAMP study, they had a few different treatments that they did, and then placebo. And it looks like they all received the same kind of follow-up. But I'll take a look at it a little bit more. And I see that the reason they thought about magnesium was because of the neuroprotection they've seen with high dose IV magnesium in severe TBI. But maybe I'll I'll look at this and present this at our journal club in Brain Sport. And if any of you ever want to join Brain Sport Journal Club, we have journal clubs on Tuesdays at 4, which is 7 o'clock your time. Just email me. We have journal club every week.
Yes, the issue of smell and loss of smell. Is anybody, both in the short and long term? I mean, this is the mechanism of concussion includes movement of the brain within the skull, usually rotation. Of course, the olfactory nerves also are affected by this inertia. Has anybody looked at the smell both immediately and in the long term to see if any change occurs?
I think there are a few studies out there looking at head trauma and olfaction. We don't, interestingly, we don't tend to ask about it, and it's not on any of the symptom checklists. I think, they've seen it definitely with the more severe injuries, and of course, the mechanism, as you pointed out, it makes sense. But again, with the shearing or stretching right in that area. But I'm not aware of any, or I haven't looked at the literature really in the post-traumatic anosmia kind of field to see, which patients are more predisposed. It's probably a mechanism or a direction of injury that will predispose you. It's another thing for me to look up. Thank you.
Another question is the issue of rugby. The rugby federations, the rugby union especially, claims that it's very rare that severe head trauma occurs in rugby as opposed to football, especially CTE, is a long-term effect. Has anybody looked at rugby? Because people are beginning to question that. What has happened in rugby is since it became professionalized about 20 years ago, you've got fast, heavy players who never used to dominate teams playing just like football. And I wouldn't be surprised if both immediate and prolonged effects occurred, both mild, moderate, and severe.
So there have been studies looking at rugby, and you're right. We've focused a lot on American football in the field. Rugby is played a little bit differently, and so the thought in the rugby field has always been that because they're not wearing helmets, they actually tackle in a different way, or they approach their opponents in a different way than American football does. And American football for a long time has tackled with leading with their head, and that has only changed over the last several decades, or even just the last decade with concussion knowledge. As far as I know, there haven't been rugby players that at least have been reported with CTE. Now, the CTE data is very skewed, right? Because you have to self-refer or your family refers, post-mortem your body to the CTE bank at Boston. And so because the press has been surrounding American football, many American football players may have referred their bodies or their brains, and their families may refer their brains to that program, and not so much for other sports participants. There are a few military in there, but I'm not aware of any rugby. I think more data will come out in all sports, not just rugby, over time. But again, it may be that tackling has been significantly different between the two sports.
It is. And also, blocking is not permitted in rugby, which it is in football.
Right. And we've seen, some football rule changes that have made a big difference, right? With kickoff, they've changed, kickoff distance and things like that, so that and we've seen fewer concussions in that setting now.
Thank you.
All right. If there's no other questions, thank you so much again, Dr. Choe, for joining us this morning. And we hope you have a great weekend.
You too.
Thank you so much. I think we all
Thank
really
you, everyone.
Thank you.
Thank you.